Go ahead.
My question is about the language and autism. During your studies, when you were looking at young kids, I know that there's a really big difference between boy who has autism and girls that have autism. Usually, girls that has autism are not diagnosed because they speak a lot. Did you see that kind of like dichotomy between like girls and boys? And was there a part in your study about that where you focused on the differences between guys and girls in communications?
So can you raise your hand? I don't know where you are, so I can. Okay. That's a good question. Yes, diagnosis when it comes to boys versus girls is very different. Like you mentioned, girls do tend to be more verbal. So I didn't mention, but this study was done not just in Canada. It was done also. A part of the cohort was done in the UK and in the US, and we had the exact same finding. So the autistic or the girls that got diagnosed with autism had really high language scores very early on. And part of the reason it's, again, you can talk about differences in biology, but we found that they had a lot of language, so they were less likely to be diagnosed simply because they're what we call, they're doing something like masking. So for a girl to be diagnosed with autism, you had to have very, very severe symptoms. So we're often mislabeled or misdiagnosed. Interestingly enough, though, when we looked at differences when it came to the brain, we didn't see anything different. So the lateralization that I was talking about was very much the same across the two sexes, regardless of whatever language scores or IQ you had. Yeah.
Did you look at any of differences in wiring between the two? Because there's a whole literature on size differences. Smaller brains are more wired. And it's often thought to underpin some of these verbal differences that you're talking about.
We didn't look at those differences. And we looked at connectivity, and we saw some patterns of connectivity being how much your brain synchronizes. So we did see some difference there. But yeah, there's been a lot of literature that talked about even like how the way the brain structurally is connected is very different between boys versus girls. And there's a lot of really cool theories on that as well. So, yeah.
I've got one for Katie. Katie, social media.
Yes.
Does that help or hurt?
I think it helped for me. And the reason I think that it helped for me was because it was a great way for me to see other women, cisgendered women, who had really stigmatized subtypes of OCD, being very candid about it, and also in real time. So I followed a series of accounts that would go live or show episodes where their OCD was flaring up, and that was really helpful to just destigmatize it for me. And also, I was very impressed at their bravery because it's an incredibly embarrassing thing to expose about yourself. So I think because it's such a shame-based illness, de-shaming it is only beneficial.
It's a very interesting perspective. Other questions? One at the back, and then the lady again.
Thank you for the very nice presentations. I do have a question about autism and language. So the question is, we have languages that are very dependent on intonation, and we also have other languages that are very dependent on the meaning, that have like several layers of meaning. So are there any studies on patients like in bilingual environments, and how do like if one patient does better in learning one language than the other or something like that? Thank you.
I really love that question, and I could talk about it it's a very, there's many layers to it. I'm going to try to be brief and tackle two aspects of it. So the first one being bilingualism. So as you mentioned, for example, we know that some languages like Mandarin are very tonal. So in those sense, the right hemisphere tends to be more active. So like I talked about, yeah, you need to have this lateralization, but when it comes to bilingual brains, everything kind of goes out the window. Like it's the way in which they're processed, even the way that they're connected is different. So like, for example, now trying to like test like kids here in Montreal that live in a bilingual setting, it's very difficult, like compared to say when we looked at the brains of the kids in the US. Where there was less of this bilingualism. So that's a really cool aspect. The second thing, there's been a lot of research related to bilingualism and autism, whether, you know, that hampers or whether we know that there's a cognitive advantage when it comes to Alzheimer's prevention and dementia. But there's a lot of studies that have shown that being raised in a bilingual setting does not lead to more autism symptoms or more likely to have delays. But what it does is that it changes how they're diagnosed. So if I give you an example, like if you have a children or two children, one of them bilingual, another one monolingual, if you're testing them saying only English, at the beginning, they're going to look about the same, right? But as they start to grow, the kid that's bilingual would have a smaller, say, for example, vocabulary in English. So to a clinician, that might seem, okay, this kid doesn't have language abilities. But you're not testing them on the other language, right? So you're not getting the full picture. And you don't really get that until they reach the age about 7 or 8 when they're kind of their two languages. So at the beginning, that kid raises some flags to a clinician when in reality, we know that that's not necessarily the case because they might only know 2,000 words in English, but they know 3,000 words in Spanish or French or something else. So, yeah.
There's a general sentiment that multilingual brains are more plastic. Is that true?
I would say so. Part of the whole hypothesis about the bilanguage advantage to Alzheimer's is that because you need to process more things in different languages, you have more connections and you have more like backup systems. So if a part of the brain starts to get lesion or it starts to die, well, you know, if whenever I think of the word red, I think of multiple languages in red. I have multiple neurons that also think about that. So if one of them dies, then I have backup plans for it. So yeah, it's more plastic. Yeah.
The lady over there first, and then the gentleman in the back.
For Dr. Gomez, I'd like to know, maybe, is there a study to know the difference between a child who can't speak yet is capable with autism to actually write their hopes and feelings, fears on a computer?
That's a good question. There's been a lot of studies on, like, I forget what they're called, but they're assistive devices. I think that there are many variables that depend with it or that go along with it. So, for example, like one of the things that we know is that if a child already has an intellectual disability, or for example, if they have a monogenic disorder, meaning they have one mutation that is very strong, the chances of them being able to develop alternative ways of communication is very slim, but it's not impossible. And there's been a lot of cases of kids that, you know, maybe verbally they're like not doing very well, but if you give them access to, say, an iPad or these different assistive devices, they do seem to help a lot. But like I said, it's a very small case, and it's case by case, I would say.
Gentleman at the back.
Thank you very much. Regarding the autistic, non-speaking individuals, it's kind of connected to the previous speaker that was speaking about nonverbal ways of communication. Mm. And we know that in autism, there is a problem with eye contact. Is there a relationship between, non-speaking kids or individuals and also those who have lack of eye contact?
That's a good question, and I would love to have Dr. Yelena here talk more about it. My understanding is that the research that says that autistic kids don't make a lot of eye contact is not, it's very inconclusive, would be the word that I would use. There's been a lot of studies that say yes, they don't look at the eyes. There's been a lot of studies that have shown the opposite, that they do look more at the eyes. So it's more of a question of how they process those social settings, right? So it's maybe they have the same input, or maybe they want to communicate, or maybe they want to pay attention to those social cues, but the way in which their brain deals with that information is different or unique. So I wouldn't say that a lack of eye contact is a symptom of autism. Yeah.
So as we talked a little bit earlier, the idea of personalized medicine is moving us away from putting people in boxes. The same sort of thinking pervades psychiatric disorders and social disorders. So people who have OCD may also be diagnosed with anxiety or depression or hyperactivity or any combination of all of the above. So Katie, I wonder if you have any thoughts for us about, from a patient's perspective, what would you like the medical establishment to do when dealing with patients who potentially have all of these comorbidities?
With any kind of comorbidity or co-occurrence, it's best to act in a triage. So to treat the thing that is causing the most distress at the time of seeking treatment. So for me, for example, last summer, I sought treatment for one of my co-occurrences, and that led me to seeking treatment for my OCD. So it was almost a pathway inward to, once there was some relief from this thing that was immediately pressing, to then have the fortitude to be able to treat this, other series of psychiatric conditions that I have.
There's a lady there first.
Yes, this is a question for Ms. Jensen.
Oh, thank you.
I was wondering, what do you think is the state of mind of a person who has external behaviors that people can see? And sometimes there will be people who will comment on behavior that is not frequently seen. And they may say, don't wash your hands so much, or things like that. And on the part of a person who has OCD, yourself, maybe others, I don't know, is there a reaction of course this is normal. Why are you criticizing this because you're the one who's not understanding what's going on? Or is it the other way around? It's like, yeah, I know this is probably not. I wish I could stop, but I can't stop. And is there a preferred way to talk about it?
If only the dialogue was that logical. Usually when a person who's trying to attempt some kind of compulsion is caught, we'll say, by somebody who's very well-intentioned, but also probably very confused, there's usually a lot of either miscommunication, a lack of clear communication, or a kind of pushing past to just complete the compulsion. So there's not a lot of explaining why you're doing what you're doing, or to say, you got me there, don't need to wash my hands 16 times. It's more like, I have to do this, get out of my way. It feels very much like either being hypnotized, which is less common, or if you've ever been inebriated and you don't understand why all of a sudden you're hungry, but you have to eat right now, and you just find yourself magically compelled. It's that sense of being pulled to do something that is absolutely out of your control, and you're almost in a fugue state while you're doing it.
No more questions? Well, that's Yelena.
I have a question for you, Katie. I'm interested from your perspective, because you had your onset as a child. What do you see the role, not your parents, but the parents can play in this kind of, behavior that they can maybe see in their children, maybe not? What is kind of the path that parents can take when their children, are not doing well?
Yeah. Counterindicatively to what we think might be good, which would be soothing the child, it's actually less helpful than seeking treatment from an external third party who can help with exposure therapy, because accommodating has been shown to make the OCD deepen. So to change your lifestyle or behaviors, let's say you have a kid who really needs you to do like a check around the room 3 times before they go to bed. And you kind of take the path of least resistance. Like, okay, my kid needs that. That is part of our new bedtime routine. That might catastrophize into 6 times, 9 times. That number might transfer over to something else. So when we make accommodations for the OCD, those brain pathways strengthen in the same way that any repetitive behavior strengthens the neural network. So we need to make sure that instead of accommodating and normalizing, that we make sure to do exposure therapy to address the root cause, the obsession, that the compulsion is just a symptom of. The obsession might have nothing to do with the room. It might be religious scrupulosity. It could be contamination. The fear might be something totally different, has nothing to do with a circle check.
Thank you very much, both. I think that's been fascinating. But
Thank you.
indeed.
You look great.
Thank you.
He's great, right?